Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Report on the Randomized Controlled Trial of a Video Decision Support Tool for CPR Decision-Making in Advanced Cancer by Angelo E. Volandes, MD. My name is Tom Smith, and I'm the Harry J. Duffy Family Professor of Palliative Medicine and Oncology at the Sidney Kimmel Comprehensive Cancer Center in Baltimore, Maryland. My oncology specialty is breast cancer, and I am also a board-certified hospice and palliative medicine physician in direct palliative care at Johns Hopkins. Cardiopulmonary resuscitation is one of the difficult issues facing patients' families and their doctors near the end of life. Unlike on TV, the success rate of CPR in real-life cancer patients near the end of life is close to zero. Study after study has documented that a very small percentage of patients actually survive the event, and even a smaller percentage, less than 1%, leave the hospital and resume normal life. We've all seen CPR lead to intubation and a trip to the ICU, only to be followed by withdrawal of life support hours or days later due to progressive clinical deterioration. This may be what some families and patients want, but most of us strongly suspect it's not. However, it's hard for patients to get real information about CPR. Most oncologists, like myself, prefer not to have these difficult conversations until there's nothing more to do about the cancer. This may be just weeks before the patient dies. Further, many oncologists are very uncomfortable having these discussions. I know I am, and would prefer to put it off or not have it at all. As a consequence, a substantial number of patients are admitted to the hospital who have no advanced medical directives. A review of outpatient charts shows that 20% or fewer patients with advanced incurable cancer have advanced directives entered in their electronic medical record. Even fewer than that have them on admission to the hospital. Yet sometimes we feel obligated to offer CPR even when we know it's going to be medically futile or close to medically futile. This gets to be an issue of avoidance behavior for patients, families, and doctors. In the report that accompanies this podcast, Volandes and colleagues from the Informed Medical Decisions Foundation randomized 150 patients with advanced cancer from 4 oncology centers to either listen to their verbal narrative describing CPR and the likelihood of successful resuscitation, or the identical narrative and a 3-minute video intervention depicting a patient on a ventilator and CPR being performed on the simulated patient. The primary outcome was the participants' preference for or against CPR, depending on whether they watched the video. The results were striking. These were typical cancer patients. The mean age was 62. Half were women and 44% were African American or Latino. 47% had lung or colon cancer. After the video intervention, 79% of patients wanted no CPR, and only 1% were uncertain. Before the intervention, half wanted CPR. This means that 30% of people switched their decision about CPR just based on watching the video. These decisions were very stable. 6 to 8 weeks after follow-up, 80% of the video group did not want CPR. Before watching the video, 41% wanted CPR. That's a switch of 40%. 93% of the intervention patients felt comfortable watching the video and did not feel distressed by it. This group has done similar work in patients with advanced brain cancer, nursing home residents, patients with dementia, and now patients with advanced cancer. Every trial has been very consistent. Those who watched the video or comfortable watching the video would recommend it to their friends and family, and 25 to 50% switched their preferences for CPR just based on watching the video. How can we use this video in clinical practice? Or perhaps the better question is, how can we afford not to use this video in clinical practice? This is a simple intervention that can help us understand our patients' preferences for decisions near the end of life. It's now been validated in multiple studies. It's readily available for purchase from the Informed Medical Decisions Foundation. The only downside to this is that it forces us to have a discussion which many of us would prefer to avoid, but that's just not good medical practice. I'm told that some advocates in the education community thought that the video was too heavy-handed, but when 93% of patients feel comfortable watching it and would recommend it to their friends and relatives, it's hard to put much stock in that conclusion. In summary, watching a 3-minute video switches the preferences for CPR to the medically appropriate do not resuscitate in 25 to 50% of patients. Patients are comfortable watching the video and would recommend it. Perhaps it's time for all of us to have this video support tool available in all our practices to help inform all our patients. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.